Welcome everyone to the call. Please confirm you can hear me. Yeah, thank you so much for joining. We'll give 1 more minute for others who are still trying to join, then we can start.
Yeah.
Yeah, I believe we can start. So my name is Dr. Asava Benson. I'm a member of CAPI and I work at Sagifarm as the QPPV, and I'll be a moderator for today. So today we are here to celebrate the World Patient Safety Day, and without taking any more time, I would like to welcome the chair of CAPI PVMA committee, under who we celebrate this day, to give us her opening remarks. So, Dr. Vivian, the floor is yours now. Dr. Vivian, we can't hear you.
Sorry. Good evening.
Now we
You
can.
can hear me now? Okay, fantastic. Good evening, everybody. I hope all of you are doing well. My name is Dr. Vivian Bote, as you heard. I work in MARC in patient safety, and MARC is a member of CAPI, and CAPI has a committee called the Pharmacovigilance and Medical Affairs Committee, which I chair, that with an awesome team of people have been responsible to put together today's webinar, of course, in great collaboration and partnership with PSK and HOPAC. So we really look forward to today and you joining us. I can see we have over 400 people on the call and people still joining, which is really great. Um, so as you can see on your screen, the theme for this year's World Patient Safety Day is safe care for every newborn and every child. So I hope that today on the call, we will be able to take a couple of insights and we can learn how we will all be able to come together and put our efforts in order to ensure a safe born for every newborn and every child. So thank you so much for your participation. We look forward to the session, and I hope that when you get the different insights from the different players who are on the call, the insights that you will get from the pharmaceutical industry, the insights that you will get from the hospital industry and also from community pharmacy, that this is stuff that you can actually be able to take home with you in your practice day to day, and especially because we are focusing on a very vulnerable group of population, which is children and newborns. And depending on your practices and your beliefs, depending on when you believe life begins, whether it's at conception or birth, then also pregnant women for their care and also the care of the children that they're carrying. So I hope that we have a great session today. Without further ado, I'd like to welcome Dr. James Mokoro, who's the chair of CAPI, to give his opening remarks.
Thank you, Dr. Vivian. Thank you, everyone. Thank you, the organizers of this wonderful webinar. As you've heard, my name's Dr. James Mokoro, working with Rekit Penkaiser as the Regulatory Affairs Manager for East Africa. I would like to take this opportunity to welcome you as the chair of the Industry Alliance for Health Products and Technologies, that is CAPI. Feel welcome, and as we continuously engage in collaborations in terms of making sure that the patients are safe, and as we celebrate this event of World Patient Safety Day, and I know we've had a series of other events on the same. So we, with the collaborations with the professional bodies, the industry members, as well as people in the supply chain, we look forward for further engagements in the same, because we all have a common agenda to make sure that the patients are safe. And at this juncture, without taking more of your time, I would like to recognize HOPAC. I don't know if there is someone from HOPAC who can give an opening remark before I invite the other stakeholders. HOPAC, Dr. Kawa, if you are around, or anyone. All right, looks like it's not been able to join, but I think will join us in due course. PSK president has requested that maybe she will be joining us later. So I think we'll recognize her once she confirms that she's online. So I think without further ado, so I think I hand it over back to Vivian to proceed, because now of course, we also recognize all the other professional associations that have joined us today. Thank you very much. Back to you, Vivian.
Super. Thank you so much, Dr. Mukoro. And then I will give you an overview of this name that you're hearing on the call, and maybe you are used to hearing, and we have now recently just rebranded officially. So CAPI, which is now known as CAPI Industry Alliance of Health Products and Technologies, is a membership organization which was established in the late 1960s. So we are just almost as old as Kenya, independent Kenya. And this association represents manufacturers, and where the manufacturers are not able to have presence in the country, then they use their local representatives. And these manufacturers and or their representatives are responsible for research, invention, and developing of medicines and technologies that significantly improve people's lives. And so CAPI serves as the industry voice that promotes efficiency in the pharmaceutical industry to ensure we improve access to high quality, safe, and effective medicine, health products, and technologies for the purposes of both diagnosis, prevention, and the treatment of diseases. So our vision and mission as CAPI Industry Alliance of HPTs is one, our vision is to be leading in the provision of innovative, world-class quality healthcare solutions, products, and services, while our mission is to promote an ethical, innovative, and responsible healthcare industry, which we work together with an amazing team of companies. And so far we do this, and our core values are ethics, integrity, excellence, and relationships. So we hold all our members to really high responsibility and regard. And what value do we bring? So one is we champion policy advocacy. So we leverage on our standing relationships, which we have great, as you heard, we established in the late 1960s. And so with our relationships, we leverage on these relationships that we have within the policy environment to engage with and inform policies towards the enabling of business environment in the health and pharmaceutical industry. So anytime there are conversations with regards to forming policies and laws that impact the healthcare industry and the pharmaceutical industry, you can be sure to have CAPI in the meeting room. We also inspire thought leadership, and with this to shape policy, practice, and healthcare trends in the country, and now even reaching a bit outside our country. We inject professional and technical acumen into different engagement forums to drive an agenda for a proactive industry. And we also provide market insights through, again, our membership and our operations in the industry. We amass key insights from the industry that is of value to our membership, and as well as in driving the industry agenda. So I hope that for any one of you who may be interested in joining CAPI, and you can see the value that we bring to our members based on our mission, our vision, and our value proposition, our doors are open. Next slide, please. So I will just let you see the current members that we have. We have a fantastic list of members who are part of CAPI. I would not be able to mention all of them, but I am sure that all of us here on the call have interacted with at least a couple of, these members, and we are all championing proper healthcare in our industry. So thank you so much for joining us, and I will let the next speaker take on from here.
Thank you very much, Vivian. So right now we are going to look at the World Patient Safety Day 2025 specifically. What is WHO telling us to celebrate this year, and what are they looking for us to improve on as we continue with our daily practice in the healthcare space. So for this section, I will be welcoming next slide, Lois. I will be welcoming Dr. Naomi Waita. Dr. Naomi Waita has over 7 years experience in the pharmaceutical industry, having worked in regulatory affairs and quality, and now in the pharmacovigilance space. She's passionate about patient safety, making a difference one patient at a time. Dr. Naomi works as the local QPPV for Johnson & Johnson. Naomi, the floor is yours.
Thank you so much, Dr. Asava. So I'll be introducing the World Patient Safety Day from the CAPI's lens and also from the WHO's lens. And we've marked these celebrations annually and worldwide since 17th September 2019. And the objectives of the World Patient Safety Day is to enhance global understanding of patient safety, increase public engagement in healthcare safety, and promote global action to prevent and reduce avoidable harm in healthcare. And I know the statement avoidable harm comes on strongly, especially for those of us who are interacting day to day with patients. And this year, CAPI, through its mission and commitment to promote an ethical, innovative, and responsible healthcare industry, we've had 2 events, which is one of them was interacting with students from UON, KU, and USIU, which was held at USIU. And we also have this webinar that is happening right now. And our intention is to uphold WHO's 2025 World Patient Safety Day objectives, which are to raise global awareness of safety risks in pediatric and newborn care in all healthcare settings, emphasizing the specific needs of children, families, and caregivers, and also mobilize governments, healthcare organizations, professional bodies, and civil society to implement sustainable strategies for safer care for newborns and children as part of the broader patient safety and quality initiatives. Additionally, empowering parents, caregivers. I believe in here there are those of us that are parents, that are caregivers, and children in patient safety by promoting education, awareness, and active participation in care, and also advocate for strengthening research on patient safety in pediatric and newborn care. Next slide, please. And we've seen this year's theme is self-care delivery for every newborn and child, with the slogan, patient safety, right from the start. And both are highlighting the critical importance of the urgent need to act early and consistently to prevent any avoidable harm through childhood, and also be able to yield healthcare benefits across the lifespan of the individual or of the patient. Next slide, please. And WHO is reminding us that children aren't small adults. They require specialized care. and they need the care that fits them within their developmental stage, their age, their weight, and I believe the person will be presenting, especially from HOPAC, will delve more into this. And also, children are more at risk in intensive care and during complex treatments. Therefore, we need to be able to protect them from any unsafe care. Next slide, please. And then most of the common causes of harm are known. That's where we talked about avoidable harm. And these include medication errors, errors in diagnosis, infections that are caught during care, and problems that can occur with medical equipment such as tubes or monitors, and missed warning signs when a child's condition starts to worsen. Next slide, please. And then safer care depends on safe systems and teamwork. And that's why during this meeting, you've seen there is great collaboration from, people from all phases, from the industry, from the hospital. We are also seeing a presentation from community pharmacy. And that way we are able to have a well-designed healthcare system, supported staff, and also not leaving behind caregivers, ensuring that they are engaged so that we keep our children safe, because every voice counts. Next slide, please. And thank you so much. I'll stop here, and the next presenter, please. Thank you.
Thank you so much, Naomi, and thank you for keeping time. So we'll go into what I consider the two main parts of our presentation for this webinar today. So we'll listen first from Dr. Bindi from the clinical side of practice, and then we'll listen from Dr. Austin Ochieng from the community side of practice. So watch out for that, and I hope you take a message or two. For those who've just joined us late, we are here to celebrate the World Patient Safety Day, and the theme Safe Care for Every Child and Newborn. So a brief introduction of Dr. Bindi is Dr. Bindi Tank is a clinical pharmacist with over 20 years experience in hospital pharmacy practice. She holds a bachelor's degree in pharmacy from Rajiv Gandhi University of Health Sciences in Bangalore and a master's in clinical pharmacy from Queen's University Belfast. She is currently the chief pharmacist at Aga Khan University Hospital, Nairobi. She is passionate about pharmacy operations, patient safety and outcomes, antimicrobial stewardship, and best practice standards. On the professional front, she holds the position of National Treasurer for Hospital Pharmacists Association of Kenya, that is HOPAC, and serves on the PPTC Technical Committee of the Pharmacy and Poisons Board. When not practicing, Dr. Bindi is an avid traveler, and her passions include nature, hiking, artworks, photography, yoga, and reading. Dr. Bindi will be sharing her slides. So over to you, Dr. Bindi, and we look forward to hearing from you. In case anyone has any question, please drop them in the chat box. Then after the two presentations, we'll have a Q&A for any questions that you may have.
Thank you very much, Dr. Sava, for that lovely introduction. Let me share my slides. So maybe Dr. Sava, you can confirm that I am audible and that my slides are visible.
Yeah, we can see. Maybe just put it on presentation mode.
Okay. Are we on presentation mode?
Yes, now we are.
Okay, awesome. Yeah. So once again, thank you very much. And I'm very much honored to be a part of this lovely meeting this evening. Patient safety is a very important topic. And I think as Dr. Mokoro has pointed out, it starts from the start and all the way to the end. And at the end of it, it's a common person for all of us is the patient. And as Dr. Nami has pointed out, the focus for us this year is on a very special population of patients who are vulnerable, which are the neonates and the pediatrics. So I hope this evening I'll be able to share with you a few things that we can all take home and mull over and put into practice. So just a brief overview of what I'm going to take us through this evening. And I imagine our listeners this evening are all people who are in practice in pharmacy. Whether you are in industry, you're in practice in a hospital or in community, I think all this is relevant. So a little bit of background to understand about starting from development of medicines and how it is important in this conversation. We're going to look at the differences between pediatric populations and adult populations. Then I will go into medication safety because the converse of safety is error. So we're going to have conversation about errors. And I'm going to take us through a real case example for us to mull over. After that, I will take us through what are the unique safety challenges that we face in pediatrics and neonates, and what is the role for us as pharmacy professionals when it comes to trying to overcome some of these challenges and making it a safer practice for our patients. So starting with the background. So we all know about medicines. Where do medicines come from? They undergo a lot of research and development before they go through clinical trials, and then they get approved and they come to the market. And one thing we must all realize is that when drugs come on market, there's limited data from the clinical trials. And have you ever heard of clinical trials happening in children largely? No, they're very limited. Therefore, any medicine that's coming to us on the market, we have limited information. So we must recognize that there do exist children who get sick, who are ill, and they will have therapeutic needs, which need to be met by medicines. And so we do have adult medicines, and they're not tested or labeled for pediatric use. So this is one thing we must recognize when we understand clinical development of medications and when they come onto market. Okay. The next thing is we must understand the concept of off-label or unlicensed use. And it is something that we take for granted because we commonly have children who are prescribed for medications. And we look at our formularies or our arsenal of medicines that we have in our pharmacies, and we try to subdivide or use it for children. But we must remember, if we go and carefully look at medicines and look at the indications, we'll see that sometimes they're not recommended for children. For example, you'll have a medication that's not has not been tested in children below 2 years, and therefore the manufacturer cannot make a recommendation on its use. So we're not sure. And so when we use it in this population, it's referred to as off-label or off-license use. So what does this mean for us when it comes to the physician or pediatrician who's prescribing these medicines for the patients? And us as pharmacists, when we are at the counter of our pharmacies, whether it be in hospital or community practice or whichever setting. So the first thing is that we don't have any information on the effective and safe dosing regimen for that drug for this population. Then for the physician, there'll be an ethical dilemma because they have to choose between using a medication off-label with little or no information about its safety or efficacy. And on the converse side, they may deprive a child of a medication that may benefit them just because they are afraid of using it off-label. And then with this situation, it becomes necessary to deal with parents. I'm sure many of us have encountered this situation where a parent has come to us in pharmacy and they say, hey, I opened the insert. My child is 1 year and 2 months old. Why has this medicine been prescribed for my child? It says here not to be used below 2 years old. Or they can't make a recommendation. So you see, the insert cannot make a recommendation. However, the physician had to prescribe this. They had no way out. So this is a challenge that we come across, and it's actually an ethical dilemma. And then when it comes to the physician and us as pharmacists, at this point, when there is an off-label use, it becomes necessary for us to recognize a greater responsibility where we are making a decision. Here is a child who needs a therapy and they need to be prescribed something off-label. So in our industry, do we have professional bodies or guidelines that guide or even defend us when it comes to off-label use or unlicensed use of medicines? So this is good food for thought for us on this forum. And then one of the challenges that we will frequently come across is that we will not have any age-appropriate formulations or even devices for administration or to deliver this medicine. And this becomes so important, for example, neonates. You may not be able to get certain types of pumps or drug delivery devices for that size of a patient. And then now, because it's off-label, warnings and possible adverse drug reactions or events, there is insufficient data. We don't know what's going to happen if we use this on this child or this population. We're not sure about the medicine interactions. And then at the end of the day, the marketing authorization holder is not going to take any liability for us using this medication in this population. And then the final question will be, we're not sure what will happen in the long run if we do risk using this medication in this population. So this is one of the background issues that we need to think about when it comes to patient safety in pediatrics and neonates. So again, as part of the background, and as Dr. Naomi has rightfully pointed out, there's a tendency to think that children are just small versions of adults. But this is not true. They're not supposed to be treated as miniature men and women. And this was quoted by Abraham Jacobi. And this is quite evident when we look at the children population. So if you look at adult medications and we look at, say, adult dosages. So for example, if you take hypertension and you take a typical medicine for hypertension, you'll find that its dose is pretty standard, whether it's 5 milligram, 10 milligram, or 30 milligram, 60 milligram. Whereas when you come to children, you can't group them as a one whole group of adults. They're actually even subdivided into categories. And the funny thing is there are very many different models of categorizing them. For example, the WHO has its own grouping. The US FDA has its own grouping. The British National Formulary for Children has its own grouping. So there's no standard way where you can say, for me, a preterm is this, a neonate is this, an infant is this. They're different categories. And this is very important because we need to recognize that we can't treat children like they're small adults because of this spectrum. There's a wide spectrum when you come to children. And then their bodies are pretty different. How they process drugs, at what level of maturity is their liver or kidney. It makes a huge difference when it comes to on guiding therapy for children, for pediatric populations. So with this background, we come to have a conversation on medication safety. So in general medication safety, we know whether it's in adults or pediatrics, it is a worldwide public concern. When we look at patients who come through healthcare systems, they're coming into healthcare system to be treated or managed. And one thing that can happen is something can go wrong, meaning that we can now aggravate the situation. They came for help. We were supposed to treat them, and they were supposed to leave the healthcare system without any adverse event. However, when it comes, it's a very high-risk system where anything can go wrong. And one thing that can go wrong with medications is what you call medication errors. Sometimes this is a taboo subject, but it is a subject that we must embrace at all levels and talk about and get a deep understanding about it. And when it comes to pediatrics, there are many published reports. However, I found so many reports came to a conclusion that harmful medication errors are 3 times more common in pediatric populations than adults. And that's telling us something. So we have medication safety issues in adults who come through healthcare systems. But when it comes to the pediatrics, we have 3 times as much error. And the background that I've just given you explains why this could be happening. And from this point, I would want to just drive one point home and for us to think very deeply. On a daily basis, we handle pediatrics or neonates when it comes to medications. The thing is, this child is very young and they have a long life ahead of them. So at this point, if we had a single safety incident that affected them, it can have a lifelong impact on their life. They have their whole life ahead to live. So if there's a medication error at this point, it might now be, it will have a lifelong impact on them. And that's why we need to be very careful about patient safety in this population. We need to recognize the fact that there is a potential of the medication use process to go wrong at all levels. We must always stay alert to this. So physicians can make an error. To err is human. They present us with illegible prescriptions. They may write a prescription for an incorrect patient. They may write an incorrect drug. So there are very many wrongs that can go at the medication level, prescribing level. Similarly, when it comes to dispensing, we can again, to err is human again for us. We can make errors. We can receive a prescription and give an incorrect dosage form or give an incorrect drug. We can give wrong directions. We may actually give them incorrect quantity. So many things can go wrong again. Once the medication is in the hands of the patient, so whether they are in an inpatient setting where they're being administered or they're at home and they're self-administering, a patient can actually make an error on themselves. And this is quite common. Patients go home and they've not understood how to use a medication correctly and they make an error. So an error can happen anywhere along the medication use process. And to further understand this, I want to point out one thing. So when an error happens, we have a typical tendency to think, oh, the doctor prescribed it wrong. Oh, the pharmacist dispensed it wrong. Oh, the patient administered it wrong, or the nurse administered it wrong. However, we must take one message home when it comes to patient safety, is that an error is never the result of one instance or one human being. It's often a culmination of small incidents that go through a whole process. And to best understand this is we have James Reason's Swiss cheese model. And this model actually takes us through a concept where we need to understand how we strengthen our systems. When it comes to the Swiss cheese, let me get a laser pointer. When you look at the Swiss cheese, you can see the various slices, and many of you know Swiss cheese has got holes in it. So what this represents is our systems. Whether it begins from the industry level, it comes to the level of the pharmacy, the distributor level, then we have the pharmacy level, whether it be the community, hospital, whatever setting. So these are different layers, and each layer must be strong enough to prevent an error from going through. However, each level can have weaknesses in the system, which is represented by these holes in the Swiss cheese. And therefore, should there be an alignment of holes, an error can reach the patient. So the more layers we have, the more opportunity for an error to be caught before it reaches a patient. Secondly, we can work on closing out these holes. So at each level, whether it's at the industry level, whether it's at the distributor level, whether it's at the prescribing level, at the pharmacy level, each level must strengthen so that there are no holes. So you can imagine if none of these slices had holes, you don't have an error going through. And to make us understand this concept about an error cascading through a system, I'm going to take us through a small case in example. And this is a medication error that happened in Denver in 1996. So this is quite detailed, but this evening, I will allow me to take you through a sequence of events that happened. So the Denver hospital actually acknowledged that they had a medication error that led to the death of a one-day-old infant who was born to a mother who had a history of syphilis. So there was this mother, she was actually Spanish and she didn't speak any English at all. And she delivered a baby in this hospital and she had communication difficulties, but they could see somewhere in the history that she had syphilis in her history. So despite incomplete information about the mother's past treatment for the syphilis and the current status of both the mother and the newborn child, a decision was made to treat the infant for congenital syphilis. So what happened is there's a doctor on duty and he actually had a telephone consultation with an infectious disease specialist at the health department. And this infectious disease specialist, after listening to him, said, advised him, and an order was prescribed for benzathine penicillin G 150,000 units IM. So this prescription went through to the pharmacy. The hospital physicians, nurses, and pharmacists were quite unfamiliar with the treatment of congenital syphilis. They hadn't encountered this very frequently, and they had very limited knowledge about this medication. So the pharmacist received this and filled the order. While filling, the pharmacist did their due diligence. They consulted the infant's progress notes, where the nurse practitioner had documented a recommendation from the health department. And they also took a drug reference book to determine what is the correct dose. So the pharmacist did what we usually do. She referred for the dose for penicillin G, benzathine for the infant. However, remember, to err is human. The pharmacist misread the dose from both the sources that she referred to, and she read 500,000 units per kilogram, which is a typical adult dose, instead of 50,000 units per kg. Just one extra zero, zero means nothing, but remember, one extra zero added over here is a 10-fold overdose. The other confounding factor here is when the prescription was written, you can see there was a U written at the end of the 3 zeros. So for the pharmacist, this looked very correct because the U looked like an O, and for she was so sure that she's got the correct dose. And then because there was no consistent pharmacy procedure for an independent double check, so this pharmacist went ahead and dispensed. There was no one else to say, hey, let's have a look and see whether this was correct. The pharmacy labeled this, and the bag that was dispensed indicated that 2.5 ml of medication was to be administered IM to equal the dose that she had calculated, which was 1.5 million units. So this medication was sent from the pharmacy to the nurses, where this one all-day baby was. The nurses looked at the medication sent from the pharmacy, and then the nurses, there were 3 nurses actually, so they grouped around and they were concerned. Remember, this was 2.5 ml, and they were concerned about giving these injections to the infant as IM, because normally you can imagine a one-day baby with very tiny muscles. And to inject, they can only give 0.5 ml per injection. So with 2.5 ml, they would have to give 5 injections. So the nurses really felt like this is going to be very painful for this really newborn baby. And wishing to prevent any unnecessary pain to the infant, 2 of the nurses decided to do a bit of groundwork to investigate and consult and see whether they could administer it intravenously instead of IM. So they also picked up a medication reference book, and they looked up penicillin G benzathine and see if it could be administered IV. However, the reference they used did not mention penicillin G benzathine specifically. Instead, it referred to aqueous crystalline penicillin G IV slow push, or penicillin G procaine IM. Nowhere in the 2-page text of this reference book was penicillin G benzathine mentioned, nor was there any specific warning regarding IM use only for penicillin G procaine or penicillin G benzathine. Now, because the nurses were not familiar with the different forms of penicillin, they made an assumption and thought benzathine must be a brand name for penicillin G. And their idea was reinforced by the fact that the physician, when they had written the prescription, they had capitalized the word benzathine above the word penicillin G. So they're like, oh, benzathine is a brand name for this medication. And so they were so convinced. Now, in addition, they used many texts, and there were ambiguous synonyms. For example, we normally see prescriptions for crystalline penicillin, aqueous suspension, and all that. So they were pretty much convinced they're on the right track, and they concluded that the drug could be safely administered IV. The nurses also knew one fact, that when you administer drugs IV, that they should usually be clear liquids. However, often we do come across certain milky-looking substances that we do administer. For example, we have lipids that are administered. We have propofol. These are white, cloudy liquids that are administered IV. And so for the nurses, they didn't think this. They thought this could be one of those exceptions again. So they felt comfortable that fine, we're on the right track, Meanwhile, the hospital policies and practices gave prescribing authority to nurse practitioners. It was not clearly defined that Are they able to change a prescription? Should they make a consultation upward to the pharmacy or the prescriber? So assuming that they were operating under a protocol that was okay, they went ahead to change this and to administer. They did not want to cause pain to this infant, and they went ahead and made the decision to administer the drug IV. So while preparing for the drug for administration, none of the nurses noticed that the pharmacist had made this tenfold overdose. Now, one thing the pharmacist had done is that labeled the syringe IMUs only. And because again, they didn't realize many other things. For example, the fact that this is an insoluble form of penicillin, and if they were going to give it IV, it's going to obstruct blood flow in the lungs for this baby. The manufacturer's warning on the label was not very prominent. It could only be viewed if the nurses rotated the syringe 180 degrees away from the drug name, and they were concerned with reading the drug name. So they began to administer the IV slow push. So when they had administered 1.8 ml, the infant became unresponsive and resuscitation efforts were unsuccessful. This baby died. Now, later on, when there was an autopsy, it was actually confirmed that this baby had not had congenital syphilis at all, and therefore never had needed this treatment to begin with. So this is a real example of a case that happened. It's an error that happened, and we normally say we must learn from error, because if we don't learn from error, we're not going to make any difference ahead of us. So now that we've gone through this case study, I want us to have some thoughts. If I may allow the audience to type in the chat box. I can't see the chat box because I'm on projection mode, but I want you to type there. I want you to think, what do you think were the causes and contributing factors to this error? Who do you think is to blame or to be held accountable for this error? And what would you recommend to prevent such an error from occurring if such a thing happened where you work? Or if you encountered this, what do you think you would implement to prevent such an error from occurring? So think about these things, and I want you to type in the chat box these thought processes. I hope we'll be able to go through as a team, or everyone can see each other's, and this can be a very nice learning case and discussion for people. But in the interest of time, probably I can maybe just summarize a few thoughts on this for us. So we need to, with this case example, we need to recognize that one, you can't blame one person, because remember the prescriber also made an error. They made a prescription without getting proper history, because remember, they later discovered that the child didn't have syphilis. In fact, what had happened is the mother had had proper treatment for syphilis, and she had 2 other babies who were born without syphilis, and therefore this baby in the first place did not need the penicillin. Therefore, if the physicians had taken time to get a proper history, this could have been avoided. Secondly, when it comes to the level of the pharmacy, if the pharmacy had a protocol to double check, then this could not have happened. When it comes to the nursing level, again, there's so many things. There could have been, again, a double check method or protocols to guide how they can make a drug change by consulting the physician. So there are a lot of things. Did anyone in this healthcare system, whether it's a physician, nurse, pharmacist, have access to good reference material that helps them to make correct decisions for patients? So I think these are learning cases about patient safety, and especially in neonates, these are very important things that we need to think about. And now when we've thought about this real case example, let's understand what are the unique safety challenges we go through when it comes to pediatrics. So in pharmacy, one is dosing complexity. You realize when patients come into a system, they're of a certain weight. When they come for the next visit, they'll have changed their weight. So we have, every time a patient comes into a system, say, and they're being managed for chronic condition, every time they come, we must weigh them and change the dose according to their new weight. So we need to have strategies and solutions. For example, we must make sure we always have standardized weight-based dosing protocols where we are. We must make reference to this, and let's have clinical decision support systems at all levels. This should not only be for hospitals, even community pharmacies should be able to access good clinical decision support systems or reference to allow them to refer to and also auto-calculate doses. Then number 2 is formulation issues. So, and if we look at Kenya, we really have this pain where we don't have many pediatric formulations, and this forces us in pharmacy to manipulate. I think many of you can attest to the fact that you've had to compound a syrup for a pediatric so that you can get a drug that can be delivered to this child. Sometimes we take to crushing tablets, advising mothers to cut a tablet. So we need to advocate for pediatric-friendly formulations to be available in this country. And I'm happy CAPI is on this conversation. This is a challenge for us that we must take up. Equally in these conversations, I think the organizations and our associations, we must look at standardized extemporaneous preparation guides, which can help all the pharmacy personnel to compound safely. 3 is we face pharmacokinetic differences in children. Like I mentioned earlier, neonates and children of those various ages, they'll have different levels of liver and kidney function, and therefore we'll need to have age and weight specific guidelines for all our patients. One thing that needs to be boosted for us is again therapeutic drug monitoring. This really helps when it comes to monitoring whether we got the dose correct for a child. 4 is communication barriers. Now you realize children are a special population because when we dispense medicines or they're prescribed, we are not telling the child how to use the medicine. We are telling a third party, meaning the guardian or the parent. Then secondly, the child cannot easily speak back to us. A good example is, say, a 1-year-old child who gets medication. They're not able to verbalize if they're having an adverse drug reaction. They may merely cry, and we may not know what's happening. So it's not easy to understand what's going on with this population when they get medications. Now, off-label use, like I've mentioned earlier, is also a high concern for us because a lot of our pediatric population, whether we like it or not, are receiving off-label medications, and we are not sure about the safety and efficacy for these medications. And one of the strategies that we need to implement in our hospitals or institution is to make sure that we probably have formularies to guide on off-label use. Because the risk with off-label is a physician or a pediatrician will be forced to manipulate a dose with their thinking or with their situation, whatever it is. However, is that off-label safe? Have they crossed the limits? If we don't have guides or formularies, we will not be able to control this. Number 6 is the fact that high-risk medications, again, with the narrow therapeutic ranges, for example, chemotherapy and the like, this becomes much higher risk in pediatrics. So we need to have safe practices. For example, we need to look for auxiliary labels on our medication, see how we can store our medicine separately, especially if they look alike. Maybe, and one thing that we must strongly implement, again, from the example that I've just shared with you, is an independent double check. Whichever setting it is, there's value in having a second human being look at what the first human being has done. In the event an error has been made, they can catch it. 7 is medication administration errors. So now once we have given medications to the caregiver, whether it's the mother, the guardian, or the nurse, we frequently encounter this and we guide them how to measure the medicine. But you see, we make a mistake at home. Mothers will use teaspoons, which are not correct. They can't use a household spoon to measure medicines. You see, again, this causes over or underdosing for children. We need to provide them with very specific syringes and cups to measure their medications. The number 8 is what we call transition of care risks. So you realize a patient or a child often undergoes transition. Within the hospital setting, it may be from a ward of one level to the other. And then the other transition is when they discharge and go home. So care is being handed over to someone else. So is the information flowing through? Because you remember when it's an adult himself or herself is taking the medication. So when they transition in care, they already have understood what they're doing, but a child is a third party. So it is very important that the mother or caregiver has understood, how is this medicine being used? How am I supposed to continue using it? It makes them so prone to error. 9 is the weight changes that I spoke about. It really misses a lot of settings because once a child is prescribed a medicine and they keep on refilling the medicine, sometimes we have a lot of miscalculated doses just because we did not bother to weigh the child over time. The 10th and last unique safety challenge that we have is the fact that we must recognize that they are a vulnerable population and they're sensitive to toxicities due to their physiology. A good example is if you take some medications, they contain preservatives. So we need to be very careful when we're using medications. We need to be aware of what are the ingredients of medications so that we do not just assume and have off-label use of some medications in children and expose them to things such as alcohol or preservatives. These are 10 key safety challenges that I'm sure you all identify with, and the suggested strategies and solutions are things we can think of implementing at our workspaces. Given this, I would like to highlight some 4 key roles that we can play as pharmacists in addressing these unique challenges. These are the take-home messages for us. First and foremost is we need to pay attention to dosage calculations. We've spoken about weight changes and a lot of nuances about the different populations. So as pharmacists, we must be very sharp with dosage calculations. I know we may not have liked mathematics in school, but we need to learn how to calculate doses. We need to pay very special attention to things such as volume of distribution for neonates. We need to be familiar with body weight-based calculations with body surface area. We need to understand calculations that are based on gestational age. You may have different drugs where you'll give a different dose if the baby was born premature, was born full term. We need to be very familiar with this, and we need to guide physicians on these. One thing that we can adopt is in our settings, if we can have automated calculators, or we can tap on AI to help us with these things, it would be the best thing. I'd like to actually demonstrate a very good example now that I know many of you probably didn't like mathematics in school, but we also need to realize sometimes being too specific, we can cause an error. And a good example is the concept of rounding of doses. So I'll just quickly look at this worked example I have here. Where you have a child who has levothyroxine per oral prescribed at 14 micrograms. And the standard formulation that we compound, yes?
Let me distract you for a minute. There's a black box on your presentation. Can you please try if it can be minimized on the...
Okay, I can't see a black box. I don't know, did it just come recently? Is it still there?
Yes.
Oh dear, shall I stop sharing and then try sharing again?
Yes.
Okay, I think maybe let me do that. Where exactly is the box?
On your bottom right screen.
Oh, okay.
Dr. Bindi, maybe when you're sharing, you can just uncheck the box that says share for video setting or something like that.
I think let me do that. Yeah, very sorry, but I don't know where it cropped up from suddenly. But yes, let me get rid of a few things there. And okay, I have shared again. Now, are there any black boxes obstructing view?
It's okay now.
We are fine? No black boxes? Okay, I can go on?
Yes, please proceed.
Okay, fine. Let me get rid of hide floating meeting controls. Okay, great. Okay, fine. So very quickly, we were doing some mathematics. I'm sure the black box came because of the people who don't like mathematics. So we have a child who needs 14 micrograms of levothyroxine, and the standard compounded formulation is 15 micrograms per ml, what we compound, and it's stable. So what dose will you advise? So if you are going to do precise maths, you will say 14 micrograms times 1 divided by 15 micrograms, and you will advise the mother that they need 0.933 ml. Now, think about it. How is the mother going to measure this? They're going to make an error trying to measure this. You can fumble around it. Do we even have syringes? Maybe a syringe that has these markings. But honestly, the mother is just going to fumble and measure her own things. Therefore, it's much easier for us to actually work out and see there is an allowance of a 10% margin And we can calculate, and in this case, we can see it's just a 7% increase. And therefore, we can have a discussion with the prescriber and agree that we will advise this child to use 15 micrograms, which is 1 ml, which the mother can actually very easily measure and give the child. So when we're looking at calculations, we can think about such concepts and apply them in practice. Okay, so sorry, so the second thing that I want to speak about that you can play a role and make a compact is compounding. So like I mentioned, there's a lot of off-label use, and we frequently come across prescriptions where we need to manipulate. So we need to understand the concept of compounding. And remember, compounding is the base of our practice. Long back before there were manufacturers of medicines, pharmacies' origins lay in compounding, and I'm so proud that we still practice it today. However, it has a very unsafe component, and we need to recognize that because there are issues with regards to stability of medications. We can actually introduce an infection when we compound medication. So we need to be very key about this. So pharmacists and pharmaceutical technologists who practice pharmacy play a vital role when we are compounding medications. We must follow established guidelines and have quality assurance procedures in place to ensure that we are compounding safely. And one thing is we can actually take ourselves through is get an understanding. Is it absolutely necessary to compound? Can I look for an alternative? Can I discuss with the prescriber an alternative? Can we commercially avail something, whether, from whether it can be imported or something for this patient? Then you can choose to extemporaneously compound. And like I say, again, we must have strict adherence to aseptic techniques when compounding. Because remember, this is a child who you can introduce to infection or contamination through the compounding process. So that is the second role that we must pay attention to. The third role is drug information and patient education. And I think it's Dr. Vivian pointed this out at the beginning. She was talking, no, sorry, it's Dr. Naomi. She pointed about empowering patients. And that is, for me, I think that's a very important thing. You see, there's this patient safety day we're celebrating today, but I think it's very wrong for us to celebrate it on. We should be celebrating it with the patients, because guess what? We're supposed to empower patients to understand patient safety so that they can take ownership about medications, which builds into safety. When we do this, because you see, we need to give patients and caregivers education, and this will translate to safe medication practices at home, because remember, they use medications at home. And I like these 5 moments of medication safety that the World Health Organization has put out there. And an easy way of remembering this is this. So you need to think about, so use the acronym STARS, S-T-A-R-S, STARS. The first S is starting a medication. Guide the patient to always think, to be familiar with their medicine. You see, they should not go home and say, oh, I've been given this green thing in a bottle and I must give 5 ml to my child 3 times a day. They must have a keen understanding. What is the name of this medication? What is it for? What are the risks and possible side effects? Then when they are taking the medication, we need to empower the patients to ask, when should I take this medication? How much should I take? What should I do if I have side effects? They even think about, what should I do if I've missed a dose? When they have a new medicine being added, they need to think about, do I really need another medication? And they can even question the prescriber, why are you adding this medication? Do I really need it? Does it have an interaction with my existing medicines? We need to empower patients to think about this. Then when they are reviewing the medications, they need to know how long do they need to take the medication. They need to understand all these things so that they're not just robotically thinking like, I went to the doctor, they wrote for me a medicine for 5 days, the pharmacy dispensed to me for 5 days, so I've taken it for 5 days. They need to understand maybe it was to be taken for 5 days and then they go for review so that the doctor can prescribe it for a further period of time depending on their tolerance. So they need to understand this concept. And then lastly, when it comes to stopping the medication, when should they stop the medication? They need to understand. And if I have to stop my medication due to unwanted side effects, where should I report this? I should be able to know that I can walk back to the pharmacy or to the physician who prescribed this. So we need to empower our patients about the 5 moments of medication safety. This is very important. Okay. And when we are doing this, one of the other few key things when we are giving drug information to patient education, remember, we also give drug information to physicians. Frequently, a physician will call and ask for your advice. Please guide me on how to dose this drug for this child who is weighing this much. When we're giving drug information or education on medication, remember, we are the guardians of medications. We must, one, give clear communication. Don't use very technical language. Be layman when you're talking to patients. We need to be, as far as possible, let me tell you, visual aids are so important. It's very important to give patients such things. Even if you have a video teaching them how to use, say, even a device, an inhaler device, do it because it really helps them. We must give them correct instructions. Please always remember, never tell them to use a teaspoon. It's very imprecise. You have to be very scientific. Okay, and then adherence counseling, they must complete their dose, the storage. These are very important things. Then emphasize them to help prevent errors. They can double check the dose themselves. You see, in the pediatric population, how many times have you come across where you've given the mother the instructions, but she goes to work and she's going to have 2 nannies in the house and she's going to tell the 2 nannies how to give this medicine. What if one nanny doesn't understand this medicine? You actually operating through a broken telephone for children. These are real risks we see when it comes to the pediatric population. They can be given a wrong dose by the nanny. So we need to emphasize error prevention to parents even as we give them medications. We need them to recognize ADRs. Again, like I mentioned in the pediatric population, they can't speak to us. So let's guide the guardians or the mothers or the fathers or the parents who are receiving this medicine on behalf of the child. And then lastly, if you have an age-appropriate child, let's empower them. Older children and adolescents can be taught about the medicines. Let us have parents involve the children to understand the medicines. Let them not treat the children like, okay, I'm the adult and I'm going to take the instructions, and when you go home, you're going to listen to what I'm going to do. Let's empower our patients where we can. Okay. The fourth and the last point that I will actually would like to highlight, the role that we play is collaboration and the multidisciplinary roles we play in whichever setting we are. One is we must participate in formulary and protocol developments because we are the ones who know medicines best. Let's sit on this forum where we can participate with other stakeholders so that we can have child-friendly formulations available and guidelines to ensure there is safe medication practice for the pediatric and neonatal population. 2 is, I think as a country, we need more research and policy, especially pediatric clinical trials. We need a lot more of this so our medicines can stop becoming off-label. Lastly, most importantly, let's be involved in multidisciplinary teams. Let's work together with physicians, nurses, nutritionists, the caregivers. Let's work together for a safer healthcare system for pediatrics. Okay. So finally, what's the future outlook for us if we do all this? One is my recommendation and thought process. Let's think about tapping into digital health and technology to make our system safer. 2, let's have formulation innovation. Again, here I would want us to push, let's push for there to be more child-friendly formulations available for us. 2, we need to strengthen the caregiver and patient engagement. All this, what I've spoken about, empowering patients, training. Let's have, and I'm happy about, I love the fact that CAPI have said that they were engaging at the university student level. We need to start talking to people earlier on, and the community as well. Let's go out there, let's get the community to participate in patient safety. 4, data and research. I won't say much more over there. We need more of this. Policy and regulation, again, we need a lot of this for us as a country. I think we need to really think about pediatric labeling requirements of medications. 6, lastly, the multidisciplinary collaboration. Let us as pharmacists go out there and integrate as safety champions for pediatric care teams. Let's go push ourselves in. Let's be involved where the care teams looking after pediatrics. Let's have shared decision making between all the calibers of healthcare practitioners. And let's look into having pediatric medication safety committees wherever we are. So this is a future outlook we have. These are some references for further reading. And thank you very much for listening to me this evening. Thank you.
Thank you so much, Dr. Bindi, for that insightful session. We truly appreciate the depth of the knowledge you've provided. and the practical takeaways that you've also given us that we can use in our day-to-day practice. We appreciate the time and the effort that you've put into delivering this very informative and engaging session. If you look through the chat box, there are a few responses to some of the questions you posed, and there are also a few questions which you can start answering in the chat box even as we approach the Q&A session. I will now welcome our second speaker for today for this main part of the presentation. So we've heard from the level of the hospital practice. Now it's also good we hear from the level of the community practice, because community is it's surely majorly the first point of contact, especially in our setting. So it's good for us to hear from someone in the community space to share our insightful thoughts on this topic. So without further ado, I would like to welcome Dr. Austin Ochieng, who is currently the chief pharmacist at Malibu Pharmacy. He holds a bachelor's degree of pharmacy from the University of Nairobi, and his major professional ambition is to improve patient care at primary care level. Dr. Austin, if you can hear me, the floor is yours.
So thank you so much, Dr. Sava, for the introduction. I'll take you through a few slides, of course, reinforcing what Dr. Bindi has taken us through, just to bring into a perspective the community pharmacy experience and what you can do as a profession regarding patient care at that level. So allow me to share my screen. Please confirm that it's visible to everyone.
Yeah, it's now visible. You can just put it on presentation mode.
Okay. Yes, so my presentation will be based on a reflection on the WHO Global Patient Safety Report 2024, and then just a few insights on what I think is important for us to consider in a community pharmacy setting. So I'll start with this statement from just a minute, I'm trying to. My screen has disappeared from my end. Just a minute. Okay, so start with this statement made by Dr. Nilam, who works at WHO, that the paramount goal of modern medicine is to ensure that treatments benefit patients without causing harm. And I think it's important for us to really think about this statement because our patients go through a lot of distress emotionally, financially, and even physically when they suffer disease. And the best we can do is to really not cause them further harm when we give them medications that we dispense to them. Just a reflection on a few points I picked from the report. The first one is that the burden of unsafe care disproportionately affects low and middle income countries, and we know Kenya is part of this. And the second one being vulnerable populations, including the older adults, children, and ethnic minorities face higher risks of patient harm. Then globally, 1 in 20 patients suffer from preventable medication harm. So 1 in 20 patients means about, let's say 5% of patients suffer from this. And out of this, 53% of the harm arise at the prescribing stage. Then it's key that we address this so that we save this vulnerable population from the heightened risk of harm. And just to look at the burden of harm by source. So the very first one is medication errors. We have others like diagnostic errors, healthcare associated infections, sepsis, patient falls, pressure ulcers, and the rest. But I've highlighted medication errors because this is our area that we need to really be keen at as far as our duty is concerned. So medication without harm is a challenge, is a global challenge that has been posted to us by WHO. And it's important that we have it into consideration as we go about our duties, especially at the community pharmacy level. We understand the environment at the community pharmacy level is quite different from probably a hospital setting or any other setting. The environment is a little hushed. Patients will want to come in and go out immediately. Sometimes we attend to a lot of patients at the same time. And many times we might miss out on very critical things that might lead to patient harm. And so it's important that we take this into consideration. The aim, the initiative was to really reduce severe avoidable medication-related harm by 50% globally. And this was to be done in 5 years. I'm not sure whether the target was met. But really, it's a call for coordinated effort from all stakeholders involved in medication safety. Basically, healthcare providers, which involves everyone, physicians, prescribers, us, and even the nurses, to have enhanced competence because being involved in a medication use process requires knowledge and technical know-how that is really important to ensure safety. Patients and the public who are always disadvantaged because they do not have the information need to be well educated and given the right information about the medications. And also looking at the product themselves, and the risk comes in, especially when you're dealing with the sound-alike, look-alike products that need to be really, we really need to be keen on as far as dispensing is concerned so that we don't mix things up. And also just a focus on storage conditions of this particular medication. Because the medication might be dispensed well, the patient goes with it, but when the storage conditions are not adhered to, they may probably not be safe by the time the patient is getting to use them. These are common process that we are used to. I just want to focus on process number 3, which is dispensing. So at community pharmacy level, we get prescriptions from all over. Some patients come with prescriptions, some come without prescriptions. For those who come without prescriptions, of course, the process is usually to listen to them, do a bit of consultation here and there, and get to understand what they're looking for and their conditions exactly. If it's something that probably needs further investigations, then we refer. If it's just a minor condition that can be managed over the counter, then we manage. And that's done by dispensing over-the-counter medications. When someone walks in the prescription, then it's the expectation that they get a professional at the counter who will professionally review this prescription and be able to prove that it is actually safe for the patient standing before them. And so that process is really very important for us. And get my point. So the first step will be to really review this prescription and review. Of course, we are used to the very basic review process, and that is checking the name, the age of the patient, the date the prescription has been written, and whether it has been stamped and signed by the doctor. But then I think we miss out on a very critical process of just looking at the medications themselves, checking whether there are any drug-drug interactions, checking whether there are any contraindications, trying to foresee probably the side effects this patient may suffer, talking it out with the patient, and basically verifying that this particular prescription is actually safe for the patient. And it's important that even as we focus on the very basic prescription validation, of just checking the name, the date, the age, and whether the prescription is signed or not, it's important that we also look at the other details. So is this medication appropriate for this particular patient? Is this patient on any other medication that could probably interact with the medications that have been prescribed? Has this patient stopped the medication, probably has been transitioned from another medication to this one? And what is really the reason why? And it's important that we look at that. Usually, if there's any discrepancy, the prescriber must be brought into the picture. And I know what we mostly do is to probably call the prescriber when we want to read their handwriting, when we are unable to, or just clarify on whether the medication can be changed to something else. But really the discussion we need to be having with them is around the appropriateness of the medication, around the condition of the patient, and really validating the prescription clinically to ensure that it's safe for the patient. Being the focus, the theme for this particular session is the newborn and children. It starts with the patient you're serving. So who is standing before you? Is it the mother? Is the mother expecting, or the mother has a young child? And whether the mother is still breastfeeding or not. And I think it's important that we confirm this particular information from the patient ordering for medication, especially if they're ordering for a young child. So if they're expecting, of course, we know that there are certain medications that are not really safe in pregnancy, and those ones need to be avoided, even on prescription or not. If they're lactating, again, we are aware that there are certain medications that they cannot take when lactating. That will probably cross into the breast milk and affect the fetus. And that needs to be put in consideration. So there are certain key action areas for medication safety. And these ones revolve around the three that I've listed here. Number one, we have high-risk situations. So high-risk situations will include probably a prescription with a high-risk medication, like insulin, anticoagulants, etc. And these high-risk situations call for heightened alert when it comes to actually looking at these prescriptions, and even the double-checking that Dr. Bindi talked about in her presentation. There's a bit of polypharmacy, taking more than 4 medications, 4 or more medications in one prescription. And of course, there's heightened risk of adverse events, drug-drug interactions when a patient is taking more than 1 or 2 medications, or rather more than 4 medications at the same time. And so again, it draws our attention to really be keen at looking at the prescription, reviewing it, and checking that everything is okay before you dispense. The third point is transitions of care, and community pharmacy level provides a unique challenge when it comes to this, because patients move from hospitals to community pharmacy. They move from other community pharmacies to other community pharmacies. They can also move from even the community pharmacy to the hospital. And the challenge we've had is there's no structured process of this movement. So a patient might miss some medication in the hospital and then come with the prescription to get the rest of the medication at the pharmacy. Because of this lack of documentation, sometimes there's a likely chance that a patient might be dispensed to the same medication they got if due process is not considered, or they might miss out on some of the information they need, because again, looking at it, counseling a patient who's transitioned from hospital to community pharmacy is difficult, because number one, you don't know what information they've been given to there. Most probably they were limited to probably the medication they were dispensed to at the hospital. So coming to community pharmacy, then where do we start? Do we just give information about the medication you're dispensing, or you give information about the whole prescription? And I think the best would be to actually go through the whole prescription with this patient, listen to them. What information were they given? Was it correct? And how do you really reinforce this particular information, or combine it with whatever you need to tell the patient of the medication you're dispensing at that particular time? Dr. Bindi has talked about this slide. She has addressed it from the point of the patient. And to us, it's important that we also work with the patient through these 5 moments of medications for medication safety. And when a patient is starting medication, what information do we give them? Even before they ask us, what information do we actually give them? Do we give them correct information? Is it comprehensive? Do they really understand that information? And when they're taking the medication, again, what information do they actually need to be able to take the medication successfully? What monitoring parameters have you availed to them, or what symptoms are they looking out for? What side effects are they looking out for from the medication, so that immediately those side effects appear, they're able to actually reach out to you and have a conversation. This is the third step of adding a medication, and really to us is adding a medication means introducing a new medication into the regimen of this particular patient. And what that means is that there could be drug-drug interactions, there could be duplications, there could be side effects that come out of adding this medication to a patient. And of importance is actually to just reconcile and see that any medication that's being added to this particular patient is not going to cause any further harm. It's actually going to be useful. There's the aspect of review of the medication, and then lastly, stopping the medication. And I think it's important that when a patient is initiated on a medication, they need to know when do they actually stop. When should they actually stop taking this particular medication? At times, you'll find a patient probably taking supplements for the rest of their lives. They were not told that you take the supplement for this period of time or something. So they probably end up spending a lot of money buying the same supplement every time, even when the usefulness of the supplement has been outlived. We are aware of this process, the medication review process, and really just to remind us that for every prescription, all the medications have to be correctly indicated. They have to be appropriate for the condition of the patient. They have to be effective. The patient needs not to be overdosed or underdosed, or given less dosage. So they have to be effective in terms of the efficacy of the drug and also the dosage that's being administered. At the same time, the medication has to be safe, meaning that the patient is not being overdosed, or the medication is not likely to cause the patient any harm because probably there were contraindications or something that could prevent the use of the medication in that particular patient. And really, most importantly, the patient needs to adhere to this medication. And looking at it from the angle of children and neonates, even if we get the first 3 right, and the patient is not able, the child is probably not able to take this medication, then it really makes no sense. And so in my next slide, I'll show the importance of having the correct formulation for especially this population we are discussing about today. So there are common risks that Dr. Bindi mentioned. I won't really go over this. Of course, the dosing errors, inappropriate formulations, medication confusion, and given the setting we are in, and like I mentioned, the rushed environment of a community pharmacy, a patient could be having probably a prescription for Augmentin 228, and someone can erroneously pick Augmentin 457 because they look alike. It's really, without a keen eye, it's really difficult to differentiate between the two. And of course, there are adverse drug reactions, and children are more susceptible. And like Dr. Bindi mentioned, they don't talk, they can't communicate. You can only see the distress. You can only see the rashes probably on their skin. And so it's important that you look out for this, and the caregivers well educated about them. We know that caregivers might misinterpret the dosing or probably use the wrong devices to administer this medication. And I think the first point is when dispensing medications is to really give the right information to the caregivers. It has to be comprehensive, it has to be right, so that they really understand all the instructions needed when giving this particular medication. And most importantly, provide the devices that are needed to administer this medication to a child. So this were mentioned, so I'll skip this. And I'm just about to finish, and I'll mention the strategies for ensuring pediatric medication safety, and just a reinforcement of what Dr. Bindi shared with us. That the first point is really prescription verification. So you have to confirm that everything is okay. A pediatric prescription is a prescription that needs to be looked into with the third eye. And probably the focus should be that the name is there, the age of the patient is there in years and months, and then the weight of the patient is included. Because again, the dosing in pediatric patients, like Dr. Bindi mentioned, is based on the weight. Sometimes it's based on the body surface area. Sometimes it's based on the age. But most importantly, the weight. And missing out the weight as information that is needed on this particular prescription gives the pharmacist or the person dispensing difficulty trying to probably proving whether the dosage is correct or not. And so it's important that that is really put there. The second bit is when dispensing, of course, when you get a prescription and you've verified everything, I know the next step is usually to go pick the medications, bring them, label, and then give to the patient. But then you skip an important process of actually finding out whether the patient is on other medications or not, so that you get an opportunity to reconcile whatever the patient has been taking and whatever is on the new prescription. These patients sometimes see different doctors. So a mother takes their child to a pediatrician and then probably another specialist and another specialist. Sometimes there's failure to actually reconcile these particular prescriptions, and there's a likelihood of duplication of therapy and probably too much drug on one patient because of different prescriptions for different specialists. And then we know our Kenyan patients, if a specialist writes a prescription, then they'll want to stick to what has been written. But then the third professional eye, which will probably come from a pharmacist, will be look at these three prescriptions, try to see whether there are any duplication, try to see whether there are any drug-drug interactions, try to see whether there is any side effect being brought by two different medications that are likely to harm this particular patient, and just reconcile. The other bit is to check whether the patient is actually allergic to any of these medications, so that everything is cleared even before dispensing. So the next step will be to counsel and educate caregivers, and they need to be given precise information about the medication. They need to be told how to store the medication. They need to be told what to do when probably an issue arises with this particular medication, how to monitor their child, how to check whether everything is working, and really how to ensure generally the safety of their child when the child is on medications. Provide killer labels and also advice on the side effects, like I mentioned, and most importantly, document the medication errors and the near misses. I know these ones go undocumented in community pharmacy, again, like I mentioned, because of the rushed environment. So medication errors are when the patient has walked out. Near misses are when now you've identified, oh, I'm about to give this, but then I've made a mistake, so you bring the patient back. It's important that these errors and near misses are documented to for purposes of learning, so that even as you sit down in a session as members of a community pharmacy, then you review and see how to actually reduce them. So I think this is my last slide, and thank you so much.
Thank you so much, Daktari, for that insightful presentation. It's very rare that you join a webinar and you leave feeling both educated and motivated. So we appreciate you sharing your passion and your expertise in your presentation this evening. Thank you so much. Without further ado, I would like to welcome Dr. Wairimu for her remarks. Dr. Wairimu, our president for PSK. Even as we come to an end of this webinar, we hear her remarks and then we'll go over to the closing session. So Dr. Wairimu, over to you. Those with questions, just drop them in the chat box and we'll make sure we find a way to respond to them.
Good evening, everyone. Am I clear? Can you hear me?
Yes, we can.
Okay, so mine is to actually close because I'm just seeing the numbers dropping. People, I think, need to just go and have dinner. But mine is to say thank you. Thank you to the organizers. Thank you to CAPI. Thank you to HOPAC. Thank you to COPAC by extension, Dr. Austin. Thank you for the insightful presentations. I think this lies squarely within our education and collaboration pillar, but also more importantly, when it comes to medication safety, I think looking at the big picture, we need to figure out all this that we are saying, how do we quantify in order to allow policy to shape some of the things that we need to do. I think that's something that we can design and think around because it's very important that as we do what we're doing, as we show our expertise, that we are also generating data that also is able to speak to the value and policy changes in terms of how we practice. Because medication safety, or what we call medication errors, should be at the heart of actually validating pharmacy as a service. So I won't go into any more details, but it's to say thank you, Dr. Mukoro, for collaborating with PSK on this. And I think the spirit is to ensure that pharmacists are at the heart of healthcare and at the heart also being visible and their work actually being recognized. And to Hezron, Dr. Hezron and the team and Dr. Asava, thank you. And yeah, those are my closing remarks.
Okay, thank you so much, Dr. Wairimu. Before we say a final goodbye, just to remind all the members, as CAPI, I just have two announcements. As CAPI, we have a pharmacovigilance training. Pharmacovigilance, how did you put the name? Outreach, pharmacovigilance outreach. For those who would be interested, it will be next week, 24th at Tamarind. So watch out for the posters and you can register to join if you're interested in the field of pharmacovigilance. We'll have industry experts sharing on that topic for the whole day. Then the other bit is we have the World Pharmacist Day next week. So hopefully to see you around for the celebrations. If you're planning anything, reach out for any collaboration opportunities and we'll be sure to join in. And finally, watch out for communication from PSK on when this webinar will be available on the PPB portal, because I'm aware it's not currently available, but it will be uploaded very soon. So watch out for that. And the CPD points will be shared too. So thank you for joining. Have a great evening. Bye-bye.